Hello class, welcome to your lecture on disorders of GI function, hepatobiliary and exocrine pancreas function. This covers primarily chapters 37 and 38, but I'm going to start out the beginning of this lecture with 2 pages from chapter 36 that discusses anorexia, nausea, and retching. You can find this information on page 913 to 914. As a general review, the alimentary tract begins with the oral cavity, continues into the oropharynx and laryngopharynx, to the esophagus, to the stomach, to the small intestine with its 3 parts, the duodenum, jejunum, and ileum. And I always remember this as the Dow Jones Industrial. Through the one-way ileocecal valve and into the large intestine, leading to the sigmoid colon, then rectum, and finally the anus. Many accessory digestive organs are involved along the way, such as the pancreas, liver, and gallbladder. The alimentary tract provides the body with a continual supply of water, electrolytes, and nutrients. This requires 1. Movement of food to the alimentary tract and through it. 2. Secretion of digestive juices and digestion of the food. 3. Absorption of digestive products, water, and various electrolytes. 4. Circulation of blood to carry away absorbed substances. And 5. Nervous and hormonal control of these functions. I'd like to start out talking about anorexia, nausea, vomiting, and retching. Anorexia, simply put, represents a loss of appetite. Appetite, or the desire of food intake, is regulated primarily by the hypothalamus. Smell plays an important role, as evidenced by the fact that appetite can be stimulated or suppressed by the smell of food. Loss of appetite is associated with emotional factors such as fear, depression, frustration, and anxiety. Anorexia often is linked to nausea, and most conditions that cause nausea and vomiting also produce anorexia. As I just said, nausea usually is preceded by anorexia, and stimuli such as food and drugs that cause anorexia in small doses usually produce nausea when given in larger doses. Nausea frequently is accompanied by autonomic nervous system manifestations, such as watery salivation, constriction of the pupils with pallor, that means a pale look, sweating, diaphoresis, and tachycardia. Nausea may function as an early warning signal of a pathologic process. Vomiting, or emesis, is the sudden and forceful oral expulsion of the contents of the stomach. The contents that are vomited are called vomitus. Vomiting, as a basic physiologic protective mechanism, limits the possibility of damage when ingested noxious agents from ingested noxious agents by emptying the contents of the stomach and portions of the small intestine. In other words, the anorexia and nausea can be protective along with vomiting, because if a food smells bad or makes you have a decreased appetite and that food is contaminated with something, well, then you're less likely to ingest it. And if you do happen to ingest that food and it's contaminated or spoiled, then the vomiting gets rid of that very quickly. Vomiting involves 2 functionally distinct medullary centers, the vomiting center and the chemoreceptor trigger zone. The chemoreceptor trigger zone is at the base of the 4th ventricle, and I show that here on a picture that's modified from your textbook. The vomiting center is in the medulla oblongata. So the chemoreceptor trigger zone, like I said, is located in a small area on the floor of the 4th ventricle. Just to remind you of your anatomy, the 4th ventricle is bounded by the pons and the medulla oblongata. The chemoreceptor trigger zone is exposed to both blood and cerebrospinal fluid. The act of vomiting consists of taking a deep breath. This is the forced inspiration, and this is to increase abdominal pressure. At the same time, there is going to be relaxation of the stomach and the pylorus. Basically, the goal is to have reverse peristalsis here. Then there's going to be relaxation of the lower esophageal sphincter. So there's this deep breath, closing of the air passageways, and then a production of a strong, forceful contraction of the diaphragm and abdominal muscles, along with the relaxation of the lower esophageal sphincter and the pyloric sphincter. Respiration stops during the act of vomiting because you don't want to aspirate the vomitus, and vomiting may be accompanied by dizziness, lightheadedness, a decrease of blood pressure, and bradycardia. If the upper esophageal sphincter stays closed, then this is retching, and the contents of the stomach will return back down to the stomach. The vomiting center receives input from the GI tract, which I show here on my picture. It also has input from the cerebral cortex, as well as the vestibular cortex, which is responsible for motion sickness, and as well from the chemoreceptor trigger zone, which is activated by many drugs and endogenous as well as exogenous toxins. Now, what about some neurotransmitters that are implicated in nausea and vomiting? Well, dopamine, serotonin, and opioid receptors that are found in the GI tract and in the vomiting center and chemoreceptor trigger zone can cause vomiting. Interestingly, motion sickness appears to be a central nervous system response to vestibular stimuli, meaning rotational movement. Norepinephrine and acetylcholine receptors are used in the vestibular center. The acetylcholine receptors are thought to mediate the impulses responsible for exciting the vomiting center, and the norepinephrine may have a stabilizing influence that resists motion sickness. Therefore, a lot of motion sickness drugs, of course, are going to target the acetylcholine receptors. Many of those drugs are anticholinergic drugs, and the best example of that is Dramamine, of course. I'd like to talk a little bit about GI bleeding. Hematemesis is basically blood that has been vomited up. Melena is blood that is in the stool, and hematochezia is blood that is also in the stool, but of a different consistency. And sorry for the gross factor, but in the top right picture, I'm showing you stool that has red occult blood in it. That's hematochezia. And then the melena is the black, thick, sticky, tarry stool that you're seeing in the bottom right picture. All of these can result from GI bleeding. Now, the most common causes of acute upper GI bleeding are peptic ulcer, gastritis, and esophagitis. The anatomic cutoff for upper GI bleeding is the ligament of Treitz, which connects the fourth portion of the duodenum to the left crus of the diaphragm. This ligament is an important anatomical landmark of the duodenojejunal flexure, separating the upper and lower gastrointestinal tracts. For example, bloody vomit or melena, which is black tarry stool, both usually indicate a gastrointestinal bleed from a location in the upper gastrointestinal tract. In contrast, hematochezia, which is bright red blood in the stool, usually indicates gastrointestinal bleeding from the lower part of the gastrointestinal tract. Let's focus on vomiting blood. Soon after the hemorrhage, the vomitus would be bright red. The color of the vomitus depends on the contact time with the hydrochloric acid in the stomach. If vomiting occurs early after the onset of bleeding, it will appear red. With delayed vomiting, it is dark red, brown, or black. If blood has been retained in the stomach, digestive processes change the hemoglobin to a brown pigment, which gives the vomitus a brown coffee ground appearance. The vomited blood might be mixed with food particles as well. Melena is the passage of black tarry stools, and hematochezia is the passage of fresh blood through the anus, usually in or with stools, and we call this occult blood. The patient having an acute GI hemorrhage will seek a physician's help because of the hematemesis, melena, or hematochezia, or because of symptoms of hypovolemia, such as fainting or lightheadedness. The examiner should ask the patient if vomiting occurred, if blood clots were present in the emesis, and if the vomitus looked brown like coffee grounds, indicating the probable presence of blood. Hematemesis indicates that the bleeding is from the upper GI tract, usually from the esophagus, stomach, or proximal duodenum. The direct question, are your stools black or bloody, should be used when active bleeding may be occurring. Make the patient understand that you mean jet black by comparing the stool color to a black object. Melenic stools also have a stickiness that the patient often remembers. Other substances such as iron or bismuth, which is in Pepto-Bismol, can turn the stool black. A melenic stool usually means upper GI hemorrhage, like I said, whereas hematochezia usually means a colonic source. The term achalasia means failure to relax. This term refers to the inability of the lower esophageal sphincter, which is a ring of muscles situated between the lower esophagus and the stomach, to open or relax and let food pass into the stomach. As a result, patients with achalasia have difficulty in swallowing food. Dysphagia is the actual difficulty in swallowing. Now, just to review, the esophagus has three functional parts. The uppermost part is the upper esophageal sphincter. It's a specialized ring of muscle that forms the upper end of the tubular esophagus and separates the esophagus from the throat. The upper sphincter remains closed most of the time to prevent food from the main part of the esophagus backing up into the throat. The main part of the esophagus is referred to as the body of the esophagus, a long muscular tube approximately 20 centimeters in length. The third functional part of the esophagus is the lower esophageal sphincter, which is a ring of specialized muscle at the junction of the esophagus with the stomach. Like the upper sphincter, the lower sphincter remains closed most of the time to prevent food and acid from backing up into the body of the esophagus from the stomach. The upper sphincter relaxes with swallowing to allow food and saliva to pass from the throat into the esophageal body. The muscle in the upper esophagus, just below the upper sphincter, then contracts and squeezes food and saliva further down into the esophageal body. The ring-like contraction of the muscle progresses down the body of the esophagus, propelling the food and saliva towards the stomach. The progression of the muscular contraction through the esophageal body is referred to as a peristaltic wave. By the time the peristaltic wave reaches the lower sphincter, the sphincter has opened and the food passes into the stomach. The person with achalasia can have a mechanical dilation, a surgical procedure that enlarges the lower esophageal sphincter, and this can be done through laparoscopy, which I'm showing you a picture of down at the bottom, a series of 4 incisions through the abdominal cavity, and a doctor can mechanically dilate that muscle. Now, tears, longitudinal tears, are known as Mahler-Weiss syndrome, and they are most often encountered in persons with chronic alcoholism after a bout of severe retching or vomiting. So it's literally tearing the esophageal muscularis. This accounts or can account for 5 to 10% of all upper GI hemorrhages. A person with achalasia can also have a lacerated esophagus, and this can be because of the trapped food that leads to ulceration. A diverticulum is basically an outward pocketing of the esophagus, and this can also lead to a lacerated esophagus, again due to the trapped food causing ulceration. Let's talk about hernias. Now, where the esophagus goes through the diaphragm, that's called the esophageal hiatus. Hiatus means breakthrough. And there can be 2 types of hiatal hernias. There can be sliding, which is also known as axial, or paraesophageal. Now, sliding. Sliding hernias are interesting. This happens when the uppermost part of the stomach, the gastroesophageal sphincter, slides in and out of the chest through the diaphragm. These hernias are generally small in nature and produce little to no symptoms. It is the most common kind of hiatus hernia, where again, just the lower esophageal sphincter slides through. Some of the symptoms of hiatal hernia involve heartburn, especially after a meal. They also have a bloated feeling or flatulence while swallowing food. Regurgitation, they may vomit food after having a meal because, again, it gets trapped in that narrow constricted area. They can have difficulty in swallowing. Like I said, that is dysphagia. The chronic swelling of the lower part of the esophagus makes the area narrow, and this makes it difficult for food particles to pass into the stomach. The difficulty in breathing, that disorder, can cause respiratory problems in older patients and chest pain. There also can be anemia. This can lead to laceration of the esophagus because of the food leading to an ulcer in the esophagus, which can lead to chronic bleeding resulting in anemia. Paraesophageal hernias are a bit different. They involve a greater portion of the stomach sliding through the esophageal hiatus, and a large part of the stomach, even all of the stomach, can then reside in the thorax. In the bottom right picture, I'm showing you a paraesophageal hernia. Nissen fundoplication, this is a procedure where the gastric fundus, the upper part of the stomach, is wrapped around the lower end of the esophagus and stitched in place. I'm showing you a picture of this in the bottom left. So the stomach is stitched in place, and this reinforces the closing function of that lower esophageal sphincter, and the esophageal hiatus, the area through the diaphragm, is also narrowed down by sutures to prevent or treat a concurrent hiatal hernia in which the fundus keeps sliding up through the enlarged esophageal hiatus of the diaphragm. So the Nissen fundoplication procedure alleviates a sliding hiatus hernia by closing off the opening through the diaphragm, and also fixes the paraesophageal hernias. Let me now address GERD, or gastroesophageal reflux disease. Reflux acid from the stomach can be aspirated into the airways and lungs, and this can make breathing difficult and cause the patient to cough. The aspirated acid can irritate the mucosa and cause a reflexive triggered nerve response, and this causes the airways to narrow. This is mediated through cranial nerve number 10, the vagus, which innervates air passageways. It's a parasympathetic nerve, so this will lead to the constriction of airways. This will cause the person to have shortness of breath and cause them to start to cough, and we associate this reflex with asthma. 50% of children with asthma also have GERD. The person will complain of heartburn, and of course the acid is going to lead to mucosal injury, chronic mucosal injury. And if we remember our discussion of cellular changes, this can lead to metaplasia. We call this Barrett's esophagus, where the squamous mucosa is replaced by columnar mucosa. Now in this picture, I'm showing you down at the bottom right the acid production pathways. Just to review, because you really should have addressed this in physiology, acid production uses a positive feedback type mechanism. More specifically, acid leads to more acid, and there are three pathways that potentiate each other. I like to say in my class, 1 + 1 + 1 doesn't equal 3 in this case, but it equals 30,000. In this picture, you're seeing that we get acid production by stimulating the parasympathetic division through the vagus nerve. We can also have G cells produce gastrin, which is a hormone, and that can lead to more acid production. We also have local control through the enterochromaffin-like cells, or ECL cells, releasing a local signal through histamine. And so what you're seeing in these three pathways, the vagus, G cells, and the ECLs, you're seeing neural, hormonal, and local controls, all three influencing acid production through the hydrogen potassium ATPase. Now, patients with heartburn, or GERD more specifically, we can treat them by giving them a histamine receptor antagonist. And you're seeing up there the cimetidine, and that's the generic term for Tagamet, as well as Zantac. These will both inhibit the release of acid. We can also give them a proton potassium pump inhibitor, which the inhibitors are going to act by inhibiting that proton pump, which regulates the final pathway for acid secretion. Omeprazole is the general term for that kind of drug. We know it better as Prilosec. A quick review of the acids and secretions in general released by the stomach. The stomach has two important types of tubular glands shown here in the mucosa. The gastric gland is found primarily in the body and the fundus, and the three types of cells that are found in the gastric gland are mucosal cells, which they don't show here in this bottom right picture, but they are there. They secrete mainly mucus. And then there's the peptic or chief cells. They secrete pepsinogen. And the parietal cells. The parietal cells secrete hydrochloric acid and intrinsic factor. Again, the bottom right picture, the purple cells are the parietal cells and the green cells are the chief cells, but also found here would be mucus cells, and those are all found, all three of those, in gastric glands. Now in the bottom part, you're seeing G cells and mucus cells, and those are found in pyloric glands found in the antrum. And again, they are going to secrete mucus for protection of the pyloric mucosa, and the G cells are going to release a hormone called gastrin, and that will circulate through the blood and ultimately target the parietal cells to release more acid. Now let's talk about the parietal cells in more detail. As I said, they secrete hydrochloric acid, and hydrochloric acid is as necessary as pepsin for protein digestion in the stomach. The pepsinogens have no digestive activity when they are first secreted. However, as soon as they come into contact with hydrochloric acid, they are changed to form active pepsin. Parietal cells also secrete intrinsic factor, which is essential for the absorption of vitamin B12 in the ileum. The chief cells release pepsinogen, which is an enzyme released in an inactive form. We call this a zymogen. Hydrochloric acid, with its low pH, is needed to activate the pepsinogen. Pepsin breaks down proteins into smaller peptides, but it is the hydrochloric acid that denatures the proteins. That means it merely unravels them from their quaternary and tertiary and secondary structures down to the primary structure. And that means that the pepsin will have an easier time to break the peptide bonds between the amino acids. There are a few types of chronic gastritis that I'd like to talk about, and gastritis is simply the inflammation of the gastric mucosa. There's the infectious type, which I will talk more about in a few slides. There's an autoimmune, a multifocal gastritis, and chemical gastropathy. In the autoimmune type, autoantibodies against the gastric gland parietal cells will basically lead to the destruction of those cells, and that means less hydrochloric acid and intrinsic factor. When acid-producing cells in the stomach are destroyed, the person develops not only achlorhydria, but also pernicious anemia. And the reason why they develop pernicious anemia in this case is because they can't absorb vitamin B12 without intrinsic factor. And so the red blood cells fail to mature. Now, this type of autoimmune gastritis is most commonly seen in patients with Hashimoto's thyroiditis and patients with Addison's disease. There is also chemical gastropathy, and what happens is the alkaline contents for the duodenum from the mucus and the mucus secretions from the pancreas and the bile, they all reflux or go back into the stomach. And this usually happens in people where they have had their stomach and duodenum sectioned and refused in a procedure called a gastroduodenostomy. That's a mouthful. Now there's also an acute gastritis, and this usually is from an overdose of aspirin or NSAIDs in general and alcohol. It basically is, again, an inflammatory response, and those drugs are irritating the mucus lining. Perhaps it is a good idea to review what is the gastric mucosa in general. I'll remind you it is simple columnar epithelium, and the columnar cells that are in the gastroduodenal mucosa have tight junctions. And this is protective so that the gastric juice can't seep backwards towards the lamina propria, which is a sheet of protein, and of course the pepsin would digest that protein. There is also, thanks to the mucus cells, a nice layer of alkaline mucus. The alkalinity of the mucus will of course neutralize the acid, and this is going to protect the columnar cells. In addition, the gastromucosal barrier has a high rate of turnover. Lots of epithelial mitosis going on, and there's cell replacement about every 3 to 6 days, and that helps ensure that those tight junctions are not compromised. There are also physiologic protections, hydrogen ions that might diffuse back into the cell. There is a hydrogen pump that will help transport those hydrogen ions right back into the lumen of the stomach. In the bottom picture here on the right side of the picture, I'm listing the protective factors of the gastric mucosa. Again, the bicarbonate-rich mucus, prostaglandins, specifically PGE2, are all very important. PGE2 is made by the COX-1 enzyme, and this is important for the alkaline mucus that is produced. If you disrupt the PGE2 synthesis, you're not going to get enough bicarbonate mucus. We also want good growth factors so that we can have high mitotic turnover. Damaging factors, the acid itself and the pepsin, if those cannot be contained and regulated appropriately, if we have excessive secretion of hydrogen and pepsin, they can both lead to damage of the gastric mucosa. H. pylori, well, that's the infectious gastritis that I'm going to tell you about in a little bit. NSAIDs, stress, smoking, alcohol, those are risk factors that can also tilt the scale. NSAIDs in particular are COX inhibitors, and that means we would lose the protective prostaglandin PGE2. That means we would lose the bicarbonate-rich mucus. So I'd like to now tell you about infectious gastritis and Helicobacter pylori, which is an adorable little bacterium up here. You can see it has these nice little flagella. And H. pylori has been found in 95% of patients with a duodenal ulcer and in 100% of patients with a gastric ulcer when alcohol and aspirin use or abuse, or NSAID use or abuse, have been eliminated. So it's a gram-negative bacterium, and students oftentimes ask, why can it live in the stomach? Well, it has a high urease activity, and that means it can make ammonium, which is a very, very strong base. So because of this enzyme, urease, they can actually take urea and make ammonium with it, this NH4+. And this, they surround themselves with this base, and the acid released by the stomach is neutralized by the ammonium created by the bacteria. Ironically, this is going to lead to an irritation of the gastric mucosa and can actually lead to increased acid secretion when that happens, which can lead to ulcers. We can test for H. pylori very easily. The patient is going to drink a radioactive urea drink. It has carbon-14, and this radioactive carbon-14 urea can be broken down by the bacteria because they have the urease activity, and they will make ammonium with it. When they do this, they also make bicarbonate, and the bicarbonate has the C14, and when the bicarbonate in the blood gets to the pulmonary capillary bed, the bicarbonate is converted into C14 carbon dioxide. And the person will ventilate this out into a scintillation cocktail. And we can take this fluid that will trap their CO2 and we put it in a scintillation machine to detect the radioactive C14. And so if it comes back positive, well, then we have to treat the patient with antibiotics and maybe even Pepto-Bismol. Your textbook says that the eradication of H. pylori has proved difficult, and usually the patient requires a combination therapy that includes 2 antibiotics with a proton pump inhibitor such as omeprazole or Prilosec, as I told you before, and bismuth. Bismuth is found in Pepto-Bismol. Treatment with the antibiotics usually lasts about 10 to 14 days, as we usually figure that out, and proton pump inhibitors like the Prilosec. And these have a direct antimicrobial property against H. pylori. You see, by raising the gastric pH, it suppresses the bacterial growth and optimizes the antibiotic efficacy. The bismuth of Pepto-Bismol also has a direct antibacterial effect against H. pylori. So that's why we use to treat, or what we use to treat patients with infectious gastritis. We give them the omeprazole, we give them the double dose of antibiotics for about 2 weeks, and we give them the Pepto-Bismol as well. Peptic ulcer disease is a general term to describe a group of ulcerative disorders that occur in the upper GI that are exposed to acid and pepsin secretions. So basically, peptic ulcer disease, we're talking about any part of the upper GI tract that's exposed to both acid and pepsin. This can lead to the most common presentation of peptic ulcer disease, which is gastric and duodenal ulcers. Now, gastric ulcers are usually a problem of decreased ability of the gastric mucosa to protect itself. What does that mean? Maybe the person is taking NSAIDs and they are restricting the amount of prostaglandin E2 that they are making, and this is going to lead to decreased bicarbonate mucus. Duodenal ulcers, well, the main problem is chronic exposure to increased amount of acid and pepsin, something like 5 times more than usual. So the two most important risk factors that can lead to these types of ulcers are 1. H. pylori, which I've already discussed, and NSAIDs. And again, the NSAIDs means that we are blocking the COX-1 enzyme from taking arachidonic acid and ultimately making prostaglandin E2. And the prostaglandin E2 is required to make bicarbonate-rich mucosa. H. pylori, like I already said, induces inflammation and releases cytokines, and this actually leads to more acid production. Again, those are the two most important causes and or risk factors for peptic ulcer disease. I've already addressed the treatment of peptic ulcers. Obviously, a person can take antacids, and that will help neutralize the acid, but that doesn't really stop the problem. The patient might need to take a histamine receptor 2 blocker. Histamine, I'll remind you, is part of the local pathway released by the enterochromaffin-like cells, which leads to the production of acid. And the common histamine receptor 2 blockers are Zantac and Tagamet. A patient can be given a proton potassium pump inhibitor, or PPI, and the most common one is omeprazole. Now that's the final pathway of acid production as seen in this picture. So if you block that, you're really going to take care of that acid production. A patient can be given antibiotics if they are infected with H. pylori, and in rare cases they can take it to an extreme level and have a vagotomy, which is where they remove the parasympathetic influence on the stomach, or remove part of the antrum, which will decrease acid synthesis. Irritable bowel syndrome, IBS. This is a chronic relapsing disorder of the gut, the entire gut. It is most characterized by abdominal pain, severe abdominal distension or bloating, and women who have this say they feel like they're pregnant. Altered bowel function, that also happens. That means the patient might have inconsistency of their stool production. It might be watery and diarrhea-like on one day, and then the next day they might be constipated, followed by days where they don't go to the bathroom to defecate at all. It's a very abnormal bowel function and abnormal stool as well. This IBS really does not have any anatomic or physiologic markers, so this type of gut disorder is basically predicated on signs and symptoms in the patient for its diagnosis.